So today we'll review monitoring techniques, understand monitoring changes, and what do we do with them. And so we've talked about this already extensively in the last two. So the lumbar plexus lives in the psoas muscle, ranges from transient neuropraxia to axonal damage and potential permanent femoral nerve injury. So it's already mentioned earlier, but the literature varies. Some studies have reported up to 34% motor weakness and up to 75% sensory issues and even 4% of permanent issues. So Bill Taylor had talked a little bit about this yesterday, but the trans-psoas approach was originally described using surgeon-directed EMG monitoring. Despite this, post-operative deficits remained. And so Sarwahi looked at a swine study, are they reliable just using EMG? And they found EMG stimulus threshold is not proportional to the distance of the nerve, and as such is unreliable in estimating how far away a nerve is while you're working. And so how about adding in transcranial motor evoked potentials, MEPs, a functional measure of peripheral nerve conduction of the lumbar plexus, and it detects impending motor deficits, particularly in the quadriceps muscle. So Riley et al. Retrospectively reviewed about 480 lateral lumbar interbody fusions at a single institution. They had 3 groups of patients: surgeon-directed EMG, neurophysiologic controlled EMG, or addition of EMG plus motor evoked potentials. All patients had spontaneous running EMG, and they evaluated post-operative sensory motor deficits for up to 12 months. And they concluded that adding MEPs did reduce the incidence of post-op transient and or permanent motor deficits. And so you can see the table on the bottom right, the percentage of deficits out to 12 months, and they found with a combination of EMG plus motor evoked potentials, you had the least percentage of deficits at 12 months. And so this is an example of what we're looking at of MEPs, and you can see it's a 2-level, so L1, L2. On the top, the red is a baseline MEP monitoring, and then you did the L1-2 graph, had your triggered EMG, all greater than 8 milliamps. Then the surgeon moved on to L2-3, and then they found with the retractor, despite having elevated 8 milliamps, the adductor muscle and the quadricep muscle started to lose their potential. And so they removed the retractor, aborted, and then at the end, the signals came back. And the patients woke up without any deficits, and this is just another example. But there are limitations to MEPs, right? So you have to have different anesthetic, you have to do IV instead of inhalation, you cannot use paralytics. It's not a continuous monitor, you have to ask the neurophysiology technologist to run a motor, and you have to have a specially trained neurophysiologist technician be able to read these outputs. So then how about if you add in SSCPs, which is a continuous monitoring thought to be sensitive to ischemic changes to the nerve. So traditionally you can monitor the lower lumbar plexus, but if you add in the sensory branch of the saphenous nerve, which is the posterior division of the femoral nerve, this allows for monitoring of the upper plexus. And we heard a little bit about this earlier from Bill's talk. And so Silverstein et al. Had a prospective study of about 172 lateral lumbar interbody fusions where they monitored the saphenous nerve, SSCP, EMG, as well as the transcranial MEPs. They had baseline comparisons of the non-femoral SSCP and EMGs. 84% of patients had monitorable saphenous nerve SSCP, and 57% of cases had good quality MEPs to monitor. Of these, 19 cases had changes to the femoral nerve evoked potential, which is a combination of all 3. And they found in the 17 of the 19 cases, the surgeon, once they were alerted, they changed their retractor or did something in response. 2 did not, and as such, those patients woke up with postoperative issues. So in conclusion of their study, they noted that femoral nerve evoked potential is essential and can help prevent femoral nerve injuries. But again, saphenous nerve SSCP signals can be difficult to obtain reliably, and they also are affected similar to what MEPs can be affected by. So this is an example of a multimodal approach. And so on the left, you have the saphenous nerve SSCPs, and you can see the squiggly lines on top. And then on the right, you have the quadriceps motor evoked potentials, and you have the squiggly lines. And so you have the surgeon, they have the retractor in, they're working along, and then the neurophysiology calls out where you see the blue arrow that the line is changing, and it's basically flatlining. And so they adjusted, the retractor was removed, and then the signals came back, and patient woke up fine without any deficits. This is an example where the surgeon did not make changes, and they continued the case, and then at the end, after retractors were removed, the femoral nerve evoked potentials did not return. The patient did wake up with deficits. So as a reminder, what the neurophysiology technologist is calling out is when you have a 50% reduction or a 10% latency in SSCPs, and you have a persistent amplitude decrease in latency in the motor evoked potentials. So what do we do? Is it retractor time? Is it retractor positioning that we should change once we get these alerts? So yesterday in one of the papers that were presented, so time isn't what makes a difference. So Patel et al. Had performed a retrospective cohort study of about 658 patients. They had an average of 17.5 retractor time, but they had 2% motor palsy around them. And they found that the time to injury did not make a difference whether it was 20 minutes or not 20 minutes. And you can see in the bottom table here that 2 out of 42 patients that had less than 10-minute retractor time still had a quadricep palsy. So what do we do? So Mundis and Isak et al. Formulated this nice table. So it's a great tree algorithm that probably a lot of people use to help. And they used multimodal intraoperative neuromonitoring with MEPs, saphenous nerve SSCPs, and then continuous EMG. They broke it down based on dilator, disc prep, trialing, grafting, closure, so each stage of a procedure. And if it's because of the dilator, then remove the dilator and maybe reposition it, start more anterior to get away from the plexus. If changes occur during disc prep, trialing, or grafting, you either reverse what you were doing, if it's reversible, or you can then go down the checklist, which is kind of in the middle right here. So has it been more than 20 minutes? Did you close the retractor and see after a couple minutes, do the changes come back? Do you look inside the field again? Do you see maybe a nerve in there? Did the psoas creep back inside? Should we take an x-ray? Did the retractor shift? Do we need to take the brake out of the bed if you had placed a brake? And then determine, is it an ischemic problem, a traumatic problem, or an anesthetic-related problem? If it's ischemic, you lower, get rid of the retractor pressure. Traumatic, not quite sure what you're going to do about that. Anesthetic, you can have anesthesia double check and make sure they did not switch over to inhalation instead of IV. If it's happening during closure, take another x-ray and then revise if you needed to. This is just a study that looked at different ways to do retractor placement, more anterior starting off and then retracting the psoas.